Well, thank you very much for that introduction. I'm not sure that I can live up to it, but I will do my best to just fly through the last 15 years of my life and the impact and the friendships and the relationships I've had with the Irish Health Service and Irish professionals who have helped me on my way. So I guess I have not met Dennis Burkitt, but I think we should start with him if we're going to talk about pediatric oncology in Africa, because he is where it all began. And we had a brief debate there whether he was as inspirational as he appears, and I certainly think that he is one of the most incredible men. And I don't think that we would be doing the things that we're doing without him. Before I got to Tanzania, the first children's cancer ward was opened in 2003. And at that time, there was, in the whole country, only one centre that looked after cancer, children and adults, called the Ocean Road Cancer Institute. And the ward that they had was a 17-bedded ward. It had literally nothing. It had beds. It had one electricity socket, and that was it. There were 3 nurses and 1 doctor. And they went home at 5 p.m. And whoever was alive the following morning, you continued with. And that was what I found when I arrived in 2006. The one thing that had continued, or that had changed, was that they had started getting access to treatment for Burkitt's lymphoma, which is actually quite easy to treat. It takes between $50 and maybe $300, depending on the size of the child, to treat Burkitt's. It's 6 days of treatment over 12 weeks. And what they had managed to do in that time period was move survival for that one condition between 2003 and 2006 from less than 10% to more than 70%. So when I arrived, I found that there was 120 kids who were seen annually. There was a less than 10% survival if you didn't have Burkitt's lymphoma. But that was because for every other condition, there was no chemo. And you cannot survive cancer unless you can cut it out, unless you can give the child some chemo. But the story of the Burkitt lymphoma children was a proof of concept. The children were not doing well in the ward, not because people didn't care or they weren't smart enough or they didn't have the ability to do this. It was that literally they didn't have the resources. The people who I met who were working on the wards and the families were the most dedicated, wonderful, warm people that I have ever met, and I really wanted to stay and help them make a change. At the time, there was also strong political will, because the Ocean Road Cancer Institute was actually free of charge for any patient to attend, and remains so today. The problem was when the cupboards were bare, and they were regularly bare, the families had to go out and purchase the drugs, and they just couldn't because they were poor, and even a $50 bill was well beyond most people. So this was the final outcome. I went first as part of a master's, and this was one of the parts of the master's that I did where I looked at the final outcome of children from 2005 in April 2006. So really incredibly short follow-up. And the only children who had any chance of survival are that little pink column. And that's literally only for some of them 3 months after they'd finished their treatment. So even that pink column, you can take it down probably 50%. And if you think that there was 120 children arriving for care in a country that at the time had about 40 million people, that would be probably less than 5% of what we would imagine was out there. So essentially, there was no survival. So what have we done in 15 years? Don't worry, I'm not going to go through all 15 years one by one. So in summary, where are we now? So our survival rates now have gone from less than 10% to approaching 60%. Our numbers of children seen have gone from 120 to last year we had 735. The chemotherapy is free for every condition, for every child in every site in the country, and that is from the organization that I set up 10 years ago called, in Tanzania, Tumaini la Maisha, and in Ireland, Their Lives Matter. The cost of this free treatment, because nothing is free and someone must pay for it, is the equivalent of about 7 children who have leukemia in Europe. The reason I know this is that there was a published study recently where they looked at all of the costs across Europe in different countries. And the cheapest place to have your leukemia treatment is in Finland, if you want to know. But 7 children completing their leukemia treatment is the cost for us to look after 730 children in Tanzania. So people often say to me, why children's cancer when there are so many other greater needs? And it is true, still infectious diseases and malnutrition are of huge concern. But one of the arguments is, it's not cost effective and, it's too much of a burden. It really is not. And it is unacceptable that we are letting these children who are very, very curable die. In Ireland, thanks to, in a large part, the enormous work that Professor Omarky, who's sitting there, has done through his career, the survival has changed from dismal to 85% for children with leukemia, and I think 90% for some of the good risk children. So why, if we're having the same children in Tanzania, why can't we have the same survival? And I'm very, very lucky that Angus and the entire faculty in Crumlin feel the same and have supported me and supported the Children's Cancer Services in Tanzania for 15 years. So Ireland has been a massive supporter of the progress that we have made. And then the other change is, as I said, when I arrived, there was one site in the country which looked after children with cancer in a 17-bedded ward. We decided very quickly that that was not going to serve a population that was rapidly increasing. There's over 50 million people in Tanzania today, and half of that population are children. And we would predict this maybe 4,500 children with cancer every year. That would cripple the health service of one hospital. They would not take kindly to us bringing all those children to one site. And also, Tanzania is a vast country, and so even getting to the site was just too difficult for many children, particularly if they're unwell. And so what we've decided to do is build a national children's cancer network. And the model is not to build anything, but to use established government and faith-based hospitals and to ask them to follow the same guidelines and the same pathway that we have established in our one site in Dar es Salaam. We have 11, we're hoping to get to 30. So what has made this change and how have we managed? Because I think we are very proud of what we have achieved, and I think it has made a dramatic difference. So the first is the setting up of the organization, which is, as I said, Tumaini la Maisha in Tanzania and Their Lives Matter in Ireland, and also a separate one in the UK called Their Lives Matter. And we had our 10-year anniversary of the Tanzanian charity last year. So what specifically was important to concentrate on? Well, the first thing was the facilities. The first thing we did was we moved the children from the cancer hospital, which was great for cancer care, but it's very well known internationally that children with cancer need to be managed in a site that has pediatrics so that you have colleagues and lots and lots and lots of different colleagues. So we moved the children about 11 years ago from the Ocean Road Cancer Institute to Muhimbili National Hospital, and overnight we had access to surgery and cardiac and renal and a 24-hour lab and a CT MRI, many, many, many other specializations. We then built a custom pediatric oncology ward, which now has 65 beds. And we also built a 22-bed hostel for the families who cannot travel home between their cycles of treatment. So they go to the hostel with their child and come back when they need care. One of the other wonderful things that we've done, I love this, even though maybe it's not the most important, but I think it's pretty important, is so when I've had cancer myself, and one of the things that it made me think about became kind of very focused on was nutrition. When I went to Tanzania first, having come from the Irish system, I always thought there's no way we'll be able to afford the Ensures and the Pediasures and all these things, these packets. And it was only after I had started changing my own nutrition and taking more care that I realized actually fresh whole foods can do the trick just as well. And so now we have 4 different products that the children get every day. They get a smoothie. We make 100 litres of smoothie every day. We do 50 litres of a special porridge. We do about 40 protein balls that we give to the most malnourished children. And we make our own special F100. So F100 is a WHO product that is great when you're trying to treat mass malnutrition. But to be honest, the ingredients are pretty gross. It's powdered milk, vegetable oil, and sugar. It is good for calories, so en masse on a scale, it's great. But what we have done is we made our own version, and it's got coconut and banana and cinnamon, and it's delicious. So that's one of the things that we do. And we also have school and play because the families live with us and the children live with us. And it's very, very important that we change the narrative of that they are patients for the entire time they're with us. Some of the children stay 6, 8, 12 months with us, or they did until we established the network. And you would find kids just staring at the wall. And our first attempt at this was literally just buying some colouring books and taking the children out under a tree. And it totally transformed the atmosphere in the ward. Now we have municipal teachers, and we have play staff, and we have play therapists, and we have clowns, and we have yoga teachers. We have all sorts of people who help the children. So it's actually, I've even had the situation where children are ready to go home and they want to stay. So very happy about that, sort of. The other thing we do is we realize that one of the barriers to care is transport, and the cost of transport in Tanzania is really is a large amount to travel, and it's because it's such a vast country. So even getting the bus costs a lot. So we now, if we are informed of a child from anywhere in the country, we can use the mobile money technology, and we can, what we call M-Pesa, which is basically send money through the phone to any one of our partners around the country, and they can buy the bus ticket for the child and the parent, and the child can then come to us even if they can't afford it. We used to see these awful referral letters which were dated a year before, where the doctor knew what it was and knew they needed to come to us and knew the care was free. And then when you asked the parents why they delayed, and they were like, we had to go home and fundraise in the village for the cost of the bus fare. So that was important to challenge. And we also now pay, the government has started a health insurance scheme. And so we have now, every child who comes into us gets a health insurance card from the charity through this fund. The idea of that is, although the service is free at our site, when they go home, when they need their follow-up and checkups, maybe the smaller sites are still charging, but the health insurance card takes away that cost. And then, as already mentioned, we have built a 12-bedded PICU and neonatal intensive care unit for the hospital. And that, I think, was one of the smartest things I've done, because we were approached by a big donor who offered us a large chunk of money to do with, we had to obviously submit a proposal, and I asked the hospital what they wanted, and this is what they wanted. I could have asked for, 5 years of chemotherapy or whatever, but because we've done this, the hospital management love us. They love our organisation. They don't feel that we steal, any source of funding that's around, that it always just goes into one group of kids. And as a result, everything in the ward is kept free of charge. So I can go in the morning, and if a child has had a seizure, I can get an MRI within an hour and report it within 2 hours. The children's surgery is free. All the tests that are available are free in the hospital. And the charity that I set up is the Charity of the Gaps. And then I do want to highlight the laboratory services. So we have been strengthening them a lot in Mumbai National Hospital, but to be honest, this is the most important area, or one of the most important areas where Ireland has just allowed children with cancer in Tanzania for 15 years to thrive. And the reason was, anytime we try and do something, you have to deal with the children in front of you while you're building something that's not there. And there was no way of making a proper diagnosis for these children because the services were not on the ground. And Crumlin Hospital, Professor O'Markey, Dr. Michael McDermott, and all of the team in Crumlin stepped in. And it is true that there was a good 10 years where samples from children in Tanzania were being sent to Dublin, and there was more children's cancer samples from Tanzania in Dublin than there were Irish children with cancer being seen. And the most remarkable part of it was we would DHL them, they'd arrive on a Monday, and the reports would start coming out Monday evening and would be completed by Wednesday. there's no service like them in the whole world. And I know because I've had loads of visitors from America, they're like, we can't even get that fast service. So that was the amazing start. And then the follow-up was that these two departments in Crumlin have since come to Tanzania multiple times and have set up both services and supported both services and continue to support as second look opinions and any backups that we need. So we now have full leukemia diagnostics in Tanzania, and in fact this year the Crumlin team are coming out to set up diagnostics in a second site so that our backup will be in country, and Crumlin will then be just the second backup rather than the primary backup. So it's amazing. And then finally, training. We've done a lot to improve training. When I was in Tanzania first, there was no pediatric oncologist. I wouldn't even have called myself a pediatric oncologist at the time. I think I've learned on the job there. But I wrote an MSc course that was accepted by the university to train pediatricians to be pediatric oncologists. We have our third intake going through at the moment. So we have about 9 pediatric oncologists trained in Tanzania, locally trained. And again, all the specialists from all manner of different areas of pediatrics have come out and been part of that training from Ireland and been amazing. And there's also been some amazing surgical trips. Professor Martin Corbally, who's a very good friend of mine, he would come out twice a year except for COVID, and is coming back in July to do, I think he's separating conjoint twins. So when he comes, he does all the oncology stuff and all these other extraordinary things. And what he does is he works with the local team on the ground so that everything is an opportunity to learn and to teach. And that's been a very important model for us. We also have an intensive course for the nurses to train as hem-onc specialists. And for the last 10 years, we've had teams from Ireland coming and training basically emergency life supports and different follow-on courses to improve children's care. So these are some of the faces that you may know. I'm afraid I couldn't find one of you, Angus. You slipped out without a photograph. The other innovative thing that we have set up is previously we used to I don't know if this has a pointer, but anyway, previously we used to do what's on the far left there, which is the handwritten sheet. And as you can see there's more than 60 inputs with literally no prompts. So you had to calculate everything. You had to know what was reconstituted with what rate it went at, how often it went. And we found that when we reviewed this process, every single one of these had a mistake in it. We reviewed about 100 of these sheets and they all had a mistake. Some of them were trivial, but some of them were dramatic and could have made a difference to the child. So what we did was we built an Excel version, a very, very clever Excel version. All of these cells sometimes have more than an A4 page of code in them. And basically you just have to fill now in the yellow boxes. And then it will populate the whole thing, do all the calculations. If the child has cardiac failure, we'll swap the drug out to something else. If they have renal failure, the same. And you don't have to do any calculations. You just have to check that the yellow boxes are correct. And what we're planning on doing is we're in the process of moving it to a web-based app, which is basically to take away the clever stuff from the user interface, because that's the difficult part about this. So the other thing, as I mentioned, was the National Children's Cancer Network, and it's got 4 tiers. That's Dar es Salaam, where I'm based. We're hoping to have primary, secondary, and tertiary sites. The tertiary sites are all the university hospitals around the country, and that's them in green there. And they will treat everything. They will look to the quaternary site in Dar es Salaam for the procurement of all of the chemotherapy and the specialist services, and some of the education and second look pathology. But otherwise, they will look after the children themselves. The yellow are the secondary sites, and they're sites that will treat a number of conditions, but not everything, but they know how to escalate and which children to move. And then the primary sites are those sites that don't actually treat, but they are actually one of the most important aspects of this network, because an awful lot of children are being stuck. They get to a site that doesn't know what to do, that reassures them, gives them drops when they actually have a cancer in their eye. And once they know how to recognize the symptoms of children's cancer, and also know that all the services that I've outlined are free and available and who to contact, we're hoping that that will make a big difference. And it already has. So our ask is for the level 1 sites, just participate. So it should be easy to get more and more of those sites into the network. And for level 2 and above, we do ask them to come on a call once a week. So I speak to every one of these centres every week and discuss every child in the country on chemotherapy. So I know what's going on, because you can start on the right path, but things can change and move, and that it's important to keep the children on the right path. They also have to be able to take samples and send them to us. And other than that, it's very simple. And what we offer is, as I said, all of these free things: free chemo, free supportive care, free backup support. If they need pathology, we will give it to them. Hematology, the same. We'll give them training, give them access to our clever chemo. And then the second thing, which is our clever charts, which is we've basically built it's kind of like an electronic medical record system / cancer registry. The idea being that you could have a child, it's useful for the child in the hospital, but it's also useful if the child needs to move for some of its care, because perhaps the chemo can be given locally, but they need to come to us for radiotherapy. And so the entire file can move if we have the patient identifier number. And that will really help with the transfer and the comprehensive nature of the move. And as I've mentioned to you, this is how we do it. So DHL are very kind, and they give us all their services free of charge, and have done for more than 10 years. So we can move samples and chemo around the country free of charge through DHL. And we also use the mobile money to send the money if we decide the child needs to maybe not come to Dar es Salaam anymore, but go to a site nearer the child. So in a way, we can move things quickly and at no cost to either the centre or the parents. And this is what we hope to see. So green is where we have coverage, and we want to cover the whole country. So the second map there, which shows still some red, that is the country covered to 95% of the population. There's just very large game parks, which you should come and see. They are really beautiful. So we also have some awareness campaigns. I'm very proud of this because we came up with this, which is the helpful early warning signs, and the acronym maps exactly to children's cancer signs. And that, again, is something we're doing nationally, and again, trying to encourage people to understand the early warning signs so that we don't have children coming with such delay, because there's no prevention really in children's cancer. So what we have to do is early intervention. And then our collaborative research. So we have lots of international trials that we're involved in. One is the AI Real study, which is a liquid knife study, trying to see if this blood test will be as effective as doing biopsies for lymphomas. We're doing that with Oxford. We're also doing a rituximab study with a group, and this is basically because there's some evidence that suggests that the dose of rituximab that's being suggested is too big. You couldn't do this study, a dose reduction study here, I don't think, but because we've no access to the drug and it's too expensive for us, having a dose reduction study is very feasible with us. The Retinoblastoma Network and the GFAOP Retinoblastoma Group, so they are the Francophone African group, and it's been a very divided continent by language for many, many years, and this group are wonderful, and they have reached across the divide, and we're doing a lot of collaborative work with them, which is amazing. Recently, the largest report on retinoblastoma outcomes, I think involving something like 130 hospitals across 53 countries, was published, and we were part of that. And then the one I'm highlighting there is the Salama study, because this is a study that we are doing with CHI and with UCD. And this I'm very excited about, because no one has ever looked at the genetics of children's cancer, children's cancer, sure, but also children's leukemia in East Africa. And there may be changes and differences with what we see here in Ireland. But very kindly, the team that wrote this grant and wrote this study for the children in Ireland, because we are doing this is being done in Ireland as well, in parallel, they included the Tanzanian children, and they're getting exactly the same study. And it will be very interesting to see what the outcomes are. So in summary then, just about the Irish support for all of this, Well, as I say, we have lots and lots of clinical opinions. I used to ring people, Angus and also Finn Brannock, on an almost daily basis because I literally had no knowledge. Recently, Finn, I called him about a very complicated child, and he said, I miss the days when you called me with easy questions. So I have learned a bit. As I've at length talked about the pathology and haematology resources, we've had lots of people down the years coming. We've had a little bit of a gap because of COVID, but I'm really hoping people will start coming back. And then the other thing is the repurposed equipment. So this, I think, is a win-win on both sides because the equipment has a carbon footprint, but when it's repurposed and the engineers check it and see that it's still valuable, it comes and gets a new life in Tanzania. And we've had some amazing pieces of kit, as you can see there, that have been donated to us. A RET cam, for example, to buy new costs 100 grand, and we were given one. And the bronchoscopy suite and the PFT labs, the management in the hospital have been begging me to try and find these, so they were just handed to me this year, which is amazing. We also have amazing Irish IT technical support. In fact, it's an IT software engineer who has built the 2 apps that I have outlined to you, and he is incredibly dedicated and charges us almost nothing for his services, so we're very, very lucky. And I think that's one of the things is about being Irish is it's so amazing how many people in this country will do stuff out of the goodness of their heart that takes them a long time to do, and no one else could do it but them, and yet they step up and they want to help. So I don't know that you'd necessarily see that in other countries to the extent that I have experienced it. I'm so lucky to be Irish, I think. We've had loads and loads of volunteers from medical students and junior doctors. We've also had international development specialists. We've one in Tanzania at the moment, and we've had musicians, we've had artists, we've had all sorts of people. And again, we're hoping that will ramp up again after COVID. If we ever see the back of it. And then finally, the fundraising. So it costs, I have to raise 1.5 million a year in order to keep this show on the road. And I'm very lucky that Irish Aid does support us. The charity Their Lives Matter that I set up here in Ireland, they do a lot of fundraising, all sorts of different events. Electric Aid, one of my favourite people, Pauline Holland is here today, and I want to thank her because I gave a talk about 12 years ago, I think it was, on Pat Kenny, I think it was, a radio show, and she rang into the show and said, I'm part of an organisation that might be able to help, and they have basically supported TLM for, since then, every year. So we have lasting relationships with our donors, and we're very grateful for that. And then some of these others here. What I just want to point out, though, is, so it looks amazing, and I'm sorry that this graph, I need to update it, is great that we're making massive progress. You can see received care and cure has really improved, but this is actually where we need to be. So statistics can be deceiving, and we can't get complacent, and there's a lot more that we need to do. Anyone in the audience who's interested in helping, there's lots of ways to help. As I said, help us with fundraising. We have a gem club, which is the Give Every Month club. Everyone who joins is a gem. We also have a piggy bank campaign, which is very much like the Throw-Cra box, but we do it during Childhood Cancer Awareness Month. And we have lots and lots of events. So this year on the 15th of October, we're having a ball in the Kilruddery House. You're very welcome to join. If you're fit, and interested in visiting Tanzania, we are also the nominated charity for the Kilimanjaro Marathon. We were this year, we are again next year. It's great fun. I did the half, but I walked around. And obviously any of the professionals or anyone who has other skills, whether you can bake or sew or sing, we welcome anyone to come and visit, to do some training, to just be alongside the children. And again, for the university, if there was a way to have students or professionals have reciprocal meeting or reciprocal visits, that would be great. Obviously, if anyone has any interesting research ideas, we're always interested in collaboration. And I just want to leave with this because this is the Royal College of Surgeons, so I just want to show you how far we've come. So this is Felix, and Felix is a little boy who has a Wilms tumor, which is a kidney tumor. I don't think you need to be a radiologist to see the tumor there. There is an arrow pointing it anyway. This tumor was so big that it had left his kidney, gone up through his vessel and up into his heart. And Hopefully this will play. Again, you don't need to be a cardiologist to see the very large lump of white bouncing in and out between his right atrium and ventricle. That's not supposed to be there. But what's amazing is going from that ward where we had literally nothing. We'd no oxygen, we'd no electricity supply, we'd nothing. And we couldn't do anything for children, really. To this point where we gave him chemo preoperatively, then 2 teams, including Martin Corbally, but all the rest of the team were Tanzanian, opened him from his neck all the way down to his pelvis. 1 team worked on his chest, opened his heart, put him on bypass, took the tumour out, sewed him up, and the other team, including Martin, opened his belly, took out the tumour and tracked the tumour up to his liver. And then this child was closed up. The sample was actually sent to Crumlin just to make sure, because we were so worried about him. The tumour was completely dead from the chemo. He still did need another 20 odd weeks of chemo, but he is alive and well, and this is maybe 5 years ago now, but this was him 10 days after his surgery. So you can see how amazing the change has been and the complexity of the care that we can offer to these children, and you can also see how cute and beautiful they are and how worth it they are. So that's it. That's what's happening in Tanzania. It's extraordinary, I think. But what's really extraordinary as well is how Ireland have really been driving the change there. And I just want to take this opportunity to thank absolutely everybody. And there's thousands of people who've helped me over the last 15 years here in the country. I just want to thank everybody for their support and all that they have offered. Thank you very much.